All right, everybody. Well, thanks for joining us on this Thursday afternoon. Today we have another one of our fantastic Advanced Heart Failure Fellows from Yale presenting. Dr. Michael Sobieraj is going to be talking to us about trying to identify factors that could make you worry about right ventricular dysfunction in patients after LVAD implantation. So, Mike, thanks for putting this together. I know you worked really hard on it, and we look forward to seeing what you have to share with us.
Thanks for the introduction, Dr. Beasley. Thanks for having me, everybody, and thanks for logging in and listening. There's a lot to it, and hopefully I summarized it well enough that we can take away a few things that may be of interest for future use and future practice. Topic of today, as Dr. Beasley discussed, would be risk factors that we know of to predict RV failure in patients with LVADs, and what went into their generation and how we can maybe use them in our own clinical practice. So my learning objectives with that would be to understand some of the physiologics that are involved with RV and how it reshapes both in terms of function and geometry after LVAD implantation, review quickly some of the hemodynamic and known imaging predictors in isolation by themselves, and then compare some of the available RV risk scores that have been developed based off of those predictors and known risk factors. And then, they come up with some basic ideas for strategies to mitigate RV failure risk, and maybe discuss as a group ways we can use that moving forward. So why does RV risk assessment matter? As I'm sure a lot of us know, RV failure can occur pretty frequently in the post-LVAD implant population. Some of the older studies have cited as much as 20%. I've even seen like 35 in some of the literature. It is, of course, associated with longer ICU hospital stays and early mortality in our patient population, and it puts a greater resource utilization strain on the individual as well as healthcare dollars for society as a whole. So it's definitely something we want to manage to the best of our ability. The clinical relevance of that would be we would be guiding our own planning, staging, patient selection, how we can manage these patients. Are they DT, LVADs? Is there a reason they need to be bridged to transplant? Like, how much risk can we take with each individual based on their own particular situation in relationship to the factors that we know about, bearing in mind that there could be a lot of variation in geographics based on organ availability for transplants in the new era where we are heavily transplant first. Um, it'll We hope that combining all these things can basically enhance management overall for the patient. So this was kind of the reason I chose this topic overall is, why is RV risk assessment so challenging to enhance my own understanding and appreciation for what goes into what we know about it and why it's so difficult. But part of it was kind of like a lack of a unified definition of what right heart failure truly is and truly constitutes, and how to measure it, how to evaluate it, and if everyone's doing that differently, how to actually look at the data that is available and understand how some people may be recognizing it at earlier versus later based on their own uh, general understanding of what it is. The most consistent used things that I've seen in the generation of a lot of these risk score calculators was usually early inotrope use within 14 days for a duration greater than 14 days, or early RVAD use, sometimes unplanned versus any RVAD use, even if it was pre-surgically planned and went out. Others include inhaled pulmonary vasodilators like nitric oxide as well as meeting that criteria. So there is a little bit of difference in how everyone is measuring RV failure, so from the get-go, so that can make it more challenging. Here's like, I really appreciate that the thought that went into a lot of the intermax definitions and how we might be able to create some consensus with it. So I did just briefly outline how it kind of evolved from a more simple definition and has progressed over time to now the MCS Academic Research Consortium definition, which actually, if I were to show you the table, can be quite long. But we have kind of further stratified phenotypes into early acute, early post-implant, late post-implant, and tried to improve basically our sensitivity to screen a different type of patient who may fail at different times. But that definition, I think, has proved to be a little bit too long and not really applied to a lot of the research studies. So just a real quick hit on like normal right ventricular physiology and why it's, so sensitive to the post-FAD uh, physiologic changes. It is just a thin-walled chamber, not very strong. It pumps usually against a low pulmonary vascular resistance, has the high compliance and a low tolerance for afterload. As afterload increases, it is preload dependent and very sensitive to any changes in the venous return system, which of course does increase. It is afterload sensitive, and it does kind of heavily rely on some septal bounce from the LV, which it may lose some of as the LVAD progresses to offload the LV, and some of the LV function may hibernate that may have been there before. The RV is, tightly linked to the pulmonary arterial pressure resistance, and there needs to be efficient transfer of the energy at normal PVRs. Otherwise, it starts to uncouple pretty rapidly. The clinical implications for this would be, that the RV can tolerate volume better than it can tolerate change in pressure, and sudden increases in afterload will put the patient at risk for acute RV failure pretty quickly. So we have to watch out. So how do the changes from LVAD support create some of these issues for the RV? Is of course an increase in venous return because we're now offloading the LV and returning the blood more quickly, and the RV has to learn how to handle the preload. There is a drop in LV pressure, which leads to a septal shift and alters the RV geometry. It actually typically will stretch it out, and the septum is usually targeted actually towards more of a midline position. So the RV now has to work with a larger geometry than what it may be typically used to, and that's in the ideal setting for the LVAD itself. There can be an increase in pulmonary vascular load, which increases the RV afterload because of the increased venous return. We kind of hit upon the ventricular interdependence. The RV does actually benefit some from the LV contraction normally, and if you offload with the LVAD, then there is less contraction from the septum to contribute to the RV. So the known risk factors, of course, would be a fixed pulmonary hypertension. We typically would be concerned with PVRs greater than 5 for any of these patients and want to try to reduce and mitigate that before we considered actually putting an LVAD in. Chronically impaired RV contractilities would also, of course, be worrisome, and sudden volume loading in some patients, which is required for heavy bleeding, puts them at risk for further RV failure. So going quickly over some of the hemodynamic predictors of RV failure in the post-FAD population, you have the pulmonary artery pulsatility index, which is essentially the pulse pressure of the PA system divided by your right atrial pressure. So it makes sense that as your pulse pressure in the PA starts to drop and match up to what's in the right atrium, that's a bad sign. Your forward pressure is becoming closer and closer to what the central venous pressure system is putting out. Um, Actually, 1.85 was shown to have a pretty good sensitivity and specificity, but as you can imagine, when you're at the point of dropping your PA pulse pressure, that tends to be a lot later in the process as opposed to like an early predictor. So it's usually not fully telling us something we may not already know about the patients inherently by itself in isolation. But that's the way I like to think of it, that it basically reflects the contractile reserve of the RV. Next, you have just your straight CVP pulmonary capillary wedge ratio. So as the CVP increases greater than your pulmonary capillary wedge pressure, makes sense that the RV would then be in trouble. There's actually two different studies that have shown two different thresholds, one being 0.63 and one being 0.54. 0.63 was shown to have an odds ratio increased of 2.5 for predicting RV failure. The 0.54 a little less so. The way I think about it is actually just if your wedge pressure is, coming down and the CVP is going up, obviously the LVAD is working and the RV is not. Another one is the RV stroke work index. That's your mean arterial pressure to minus your right atrial pressure multiplied by your stroke volume index, and then there is a coefficient there, which you also multiply it by. Less than 400 has been shown to have an increased risk for RV failure postoperatively, and less than 250 has been shown to have an even higher risk and is more concerning. So it could be helpful to better stratify in your own mind how high risk the patient is. I like that it's got two cutoffs, so that you can actually stratify even further for the severity levels. And less than 250 was about a 3 to 5 time 3 to 5 fold increase in the risk of needing some biventricular support in the postoperative setting. Next, we have a straight mean arterial pressure CVP ratio. Threshold published there was 7.5 with a sensitivity of 70%, but a specificity of only 56%. Kind of reflects the perfusion pressure versus venous congestion, and it, of course, lower values are suggestive of worse outcomes since there's less pressure within the pulmonary system relative to the CVP. These ones I just added because a lot of the studies sometimes try to incorporate them, but it makes sense that if the LVAD is working and your cardiac index is still low, most likely your problems with the RV. And central venous pressure tends to be self-explanatory. If the RV is not moving blood forward, that will increase. And for those who like tables, because I tend to like seeing tables and be able to compare things side by side to evaluate their utility, here's a couple of tables showing the various hemodynamic predictors from different published studies. And this one was actually just a single center with Marine et al., but they did show that the PAPI had the highest area under the curve relative to everything else. And then just to go real quickly through, because each of these would be almost a lecture in and of themselves to explain, but some of the imaging predictors used to evaluate post-LVAD failure, RV failure, would be the RV-LV end-diastolic diameter ratio, which just show RV dilation disproportionate to RV in disproportionate remodeling associated with higher RV risk of failure. TAPSE less than 1.7, of course, is showing less longitudinal RV function and tends to be one of the favored echo parameters because it was shown to have a reasonable specificity, is less impacted by the change in geometry because it's, the longitudinal motion as opposed to lateral and twisting. Fractional area of change was used as well. The free wall strain, if you have it, has been proposed to be a reasonable marker. I mean, the specificity of 76% and sensitivity of 68%, an area under the curve of 0.7. So it's actually pretty reasonable. Moderate to severe TR is often used. The IVC diameter was looked at. Septal flattening and D-shaped is, of course, a sign of RV failure. And then if you have it, right atrial strain in some small studies has actually been shown to be a reasonable predictor of RV failure post LVAD with an area under curve actually of 9.91. But those are some smaller studies and not widely used as of yet. Additional modalities, hopefully, that will be leveraged more heavily would be 3D RV volumes by either CAT scan or MRI in patients who are stable enough to get it prior to transplant, although that's often not always the case. And I also had some tables here which compare them if you're the table type. So I combine the modalities because obviously not one of them by themselves and in isolation is proven to be a very successful predictor of, postoperative RV failure. So we try to combine them to complement the strengths and weaknesses of each thing individually. And we got to continue to try to use what we have to the best of our ability to evaluate the patient and understand how high the risk is and what we can do for it. Here are some of the risk models as they have been developed over time. Oops. This is a summary slide, which we won't go over, but for whoever likes slides, it's very comprehensive and has pretty much everything for the most part that we're about to go over in one nice detailed table. So first off, we're going over the Michigan right ventricular failure score. It was developed from HeartMate 2 cohort of 197 patients and emphasized, end organ dysfunction and hemodynamic instability within it. As you can see, the variables are a vasopressor requirement. There is an AST level and total bilirubin as well as creatinine. So they're looking for markers of end organ hypoperfusion. They assigned different point schemes based on their retrospective analysis of what they've determined the variables to be weighted, and basically came up with a little bit of a risk stratification showing that most importantly, greater than 5.5 points actually had a positive predictive value of 80%. 24 of the 30 patients with RV failure actually were predicted by the score to go into RV failure. They defined RV failure as a need for RVAD or inotrope support for 14 days. The area under the receiver operating curve, though, was not super great or strong. It was 0.61. But, a score of greater than 5.5 is predicting basically a 15-fold increase in the risk compared to someone who would be in the lower risk category of less than 3, which is a pretty substantial change. Obviously, limitations for our use is, this is a much older study and not going to be reflective of the current HeartMate 3 exclusive almost era that we live in currently, which is a problem with most. So another scoring system from the 2008 era is the Penn score. They use the variables cardiac index, RV stroke work index, severe RV dysfunction, creatinine, history of previous cardiac surgery, and your systolic blood pressure, assigning each of those categories a 1 point each. And they set a high risk threshold on their evaluation of 3 points, which was associated with an increased RV failure risk. They defined actually RV failure as the need for RVAD, and they had an area under the curve of 0.74 with that. And then once you plug in each one of these points, what you do is you multiply that number for each area, for each thing. So it's not like you put in the actual cardiac index and multiply it, you just put a 1 in and it gains the 18. Same thing with the RV stroke volume worked index. If it's less than 250, you get a 1. The creatinine is greater than 1.9, you just put a 1 in. So each of these things adds up to give you the score. And the score greater than 50 predicted RV failure post-implant with sensitivity of 83% and a specificity of 80% in their original publication. There wasn't a external validation cohort that I saw though for this one at the time that they created it. And of course it was also pre-HeartMate 3. And as we go on, there's the Dracos or Utah score from 2010, developed at the University of Utah and affiliated hospitals with 175 patients. It's primarily axial flow HeartMate 2s. They came up with weighted scoring points as they evaluated each risk factor, with their risk factors or the variables being LVAD as destination therapy, intra-aortic balloon pump use, pulmonary vascular resistance of less than 1.7 Woods units, inotrope dependency, obesity, ACE or ARB use, and beta blocker use. And the ACE or ARB use was actually given negative points for the puts the score the opposite direction. Patients with a score threshold of greater than 12.5 had an 11.4 increased odds of RV failure postoperatively, although you can see the confidence interval is pretty wide on that. RV failure was defined as need for RVAD or inotropes greater than 14 days in duration, and the area under the curve for this one was 0.74. The limitations are that it was just the University of Utah, like an affiliated hospitals driven, and again, not including HeartMate 3. In 2013, a CRIT score was developed with, I believe, Cleveland Clinic and affiliated hospitals. It was derived from 218 continuous flow LVAD recipients. They gave each variable 1 point, and high CRIT score being 4 or equal to or greater than 4 was strongly associated with increased incidence of RV failure. Low score was less than 3 and demonstrated a negative predictive value of about 93% for not needing it. The area under the curve for that was 0.8. And the thing that was intended to be good about it is that they tried to make it simple. It's just the central venous pressure, severe RV dysfunction by echo, which was qualitatively measured. So there's a lot of bias and variability in how that may have been reported within the groups. There's preoperative intubation, tachycardia greater than 100, and severe tricuspid regurgitation, which was again being evaluated both qualitative and quantitatively. And it was still heavily driven by older iterations of the LVAD populations. Also published in 2013 was the HeartMate 2 risk score. The variables included were age, albumin, creatinine, INR, and center of LVAD volume, which they defined as greater than or equal to 15 implants per year. It was actually pretty large. They had a sample, like it was originally developed from a sample size of 1,122 patients with HeartMate 2s. We broke it down into derivation cohort of 583 and the validation cohort of 539. They stratified the patients by 90-day mortality risk post LVAD, and reduced cardiac output was found to be predictor of mortality, but not specific to RV failure, which was not surprising. The limitations of the score were that it's predicting general mortality, not specifically RV failure, but it was developed for the axial flow era. Another risk score that's actually more of a decision pathway was the Pittsburgh decision tree, which you can see there are multiple checkpoints or nodes, as they like to call them in the publication, where you progress down the flow chart, and it'll actually tell you at the end whether or not they think you need an RVAD based on the different risk factors, which included transpulmonary gradient greater than 7, age greater than 59, right atrial pressure greater than 18, INR, heart rate, white blood cell count, alien aminotransferase, and the number of inotropes. They developed it using what's called the classification and regression tree analysis. And as we were discussing, it basically just creates a hierarchical algorithm with actually TPG, age, and right atrial pressure being the most significant, impacting your decision making. The limitations are it is kind of complex, and you would probably need to look at it at the bedside, and there's no real risk breakdown of higher risk versus lower risk by looking at the table. It's just yes or no for whether or not you should consider an RVAD. And this was based on the pre-HeartMate 3 era, and was only internally validated and not externally. In 2015, there was the RVAD score as well. This was from 42 patients in the Germany LVAD registry with scores ranging from 0 to 6.5. They defined RV failure in that score system as need for prolonged inotropic support greater than 14 days, right ventricular assist device implantation, or death due to RV failure. The high-risk threshold was set at greater than or equal to 3 points. The performance metrics, as they evaluated it, came out to show a sensitivity of 89% with a specificity of 74%, and predicting those things with an area under the curve of 8.87. Obviously, limits were that it's a small sample size, still heavily the pre-HeartMate 3 era, and likely maybe a little bit of an oversimplification of the situation, and also the Intermax 1 representation within this score system was extremely high. In 2019, they made the MCS or N score, which is from the Mechanical Circulatory Support Research Network database. They used 734 subjects between 2004 and 2014, which was 76% heart rate 2 and 24% HVAD, and still not HeartMate 3 included at this point. Of that original sample size, 33 developed RV failure, so they broke that down into a derivation cohort of 15 and a validation of only 18 to make the equation. RV failure was defined as the need for RVAD or inotropes greater than 14 days post-LVAD implantation. The high-risk threshold that they found when developing this equation was greater than 22, which was associated with a 78% incidence of RVAD utilization. and their derivation and validation area under the curves were 0.89 and 0.92 respectively. I think the limitation here was that ultimately the number of patients with RV failure that they were able to use to come up with this equation was quite small. And again, there's no inclusion of heart rate 3 subjects within it yet. It would also probably be quite difficult to pull up a calculator and do this at the bedside. Recently, there was the Stop RV Failure Score, which was published in 2024. This was actually a hybrid prospective and retrospective multi-center cohort, but it did have a long period that it looked back through and included up to. So it did go all the way back to April of 2008 to and up to July of 2019. RV failure was defined as a need for RVAD or IV inotropes for greater than 14 days, and it was derived from 798 patients, externally validated an additional 327 patients. But it did include heart rate 3. There was a 15% representation of heart rate 3 patients within it. RV failure occurred in about 24.2% of the derivation group and 32.7% of the validation groups, and each variable was then assigned coefficients which are summed. The low risk group was determined to be less than 20%, moderate risk 20 to 49%, and high risk greater than or equal to 50%. The area under the curves for both the derivation and the validation groups of this score system were 0.75 and 0.73 respectively. They mentioned how it outperformed prior studies. I think the limitations are that it's still pretty hefty and includes a lot of like semi-quantitative variables. And also there was a heavy like intermax 1 or 2 population representation. But the nice thing is actually they posted calculator that they made based on this that you can actually use and go to at the bedside on like one of the computers on wheels or at your own like desk. So you can actually go to their website, pull up this table and answer the questions for your own patient. And it will actually give you a predicted probability of RV failure and tell you what group they think that's in. So I just added some numbers and made up a patient, and it put out for me a 35.48% risk prediction of RV failure post-implant, which is in their moderate risk category. So it tells you both an actual percentage that they think, as well as, what general group they think that should be within. And then over on the side, you see actually the coefficients, which they summed to create this and then you use the linear regression equation for it. This one I actually included because I think in spite of it not gaining traction, it had a lot of things that I think are missing that could hopefully open up more opportunity to better predict who may fail in the future. They proposed this Sienna score looking at just echocardiographic criteria, and then they selected the ones that with smaller studies had the best fidelity and best area under the curve for being correct in predicting post LVAD RV failure. And those 4 were the free wall longitudinal strain, which the data was right around -11% in a couple of studies, some a little bit higher, some a little bit lower. Fractional area of change, which everyone, of course, set at 35%. The RV ejection fraction, which they set at 35%, and the RV sphericity index, actually, which had some predictors around 0.5 in a couple of small studies. And they were proposing this like whole study that, to my knowledge, hadn't happened yet. So clinical applications of a lot of these things. And we can use them to help with surgical planning. We can use them to make sure we're vigilant and diligent about volume status management, reducing the pulmonary vascular resistance, and improving contractility preoperatively if we're able to. Um, Bearing in mind pH therapies would usually be after adequate diuresis. The other thing is, of course, the consideration for prophylactic RVAD, which only the decision tree from Pittsburgh was specifically geared towards trying to determine versus inotropes and pulmonary vasodilators alone in the high-risk patients to bridge them through the RV, adapting more gradually to the changes in both geometry and function. So of course, a multidisciplinary heart team is essential as we don't have any clear-cut evidence or guidelines to specifically guide us through this. So of the things that I actually want to be the main takeaways from this discussion, I think, first and foremost, preoperative RV dysfunction will predict postoperative RV dysfunction. You have a bad RV going in, you're going to have a bad or worse coming out. And we need to be mindful of that as we choose how to approach the situation and manage it postoperatively for the patient, preoperatively, perioperatively, and postoperatively. I think it's essential to meet up and have a heart team approach because, again, we're a little bit coming up with it as we go and decide how we want to approach it with inotropes, pulmonary vasodilators, or prophylactic RVAD, or everything all combined. I do think it's important to discuss setting realistic expectations for the patients who we identify as high risk for RV dysfunction postoperatively. Because I have one more slide about the outcomes for patients with risk factors in the HeartMate 3 momentum population. Because someone's going in with an RV that's already struggling is going to potentially burn out faster. So we need to tell them, it's high risk for the surgery itself, but that we aren't really sure necessarily how far they can go relative to someone who's the perfect candidate for an LVAD. And I do think we should make sure the patients are aware of that because we want them to know we're doing our best to get them the best that we can, but maybe they don't come out on the positive end of 58% at 5-year survival. I think the PAPI and the right atrial pressure, the pulmonary capillary wedge pressure, as well as LRP dilation are all pretty well validated and can help you interpret the situation for the patient if they happen to have all three of these things combined. I do caution to bear in mind that the hemodynamics fluctuate. That's one snapshot in time when you get one number, so you really need to trend them and see what the overall average trend is, because you might get a PAPI of like 1.3 if you happen to pick the right time that this one just happened to spit that number out. And then, all of a sudden you're at 2.5. So I do think you have to bear in mind that risk scores support but do not replace clinical judgment. And I think it's important to remember that all of these risk scores currently are heavily influenced by prior generations of durable LVADs, as well as the prior transplant like listing criteria, which has impacted how we choose and select who gets VADed, and that there is a lot of potentially geographic differences in who's getting which therapy where, and what the demographics of the LVAD population look like now versus what they looked like, back in 2014 or even before that. And then I just wanted to show this slide because it, again, reiterates this is for risk factors like altogether. It's not specific to RV failure. And RV failure was combined with a heart failure as a composite. They just called it like cardiovascular as a frequency and cause of death, but patients with progressively more risk factors have a lower survival, going all the way down to 43.5% at 5 years for the patients with pre and post transplant or implant risk factors. So that's I think why it's important that we do be mindful with the patients so that we know have high risk for RV failure going into it, that, we let them know that we aren't sure, how far it can take them, but, we're gonna do everything that we can for them to get them as far as we can take them. And that was it.
Great, Mike. Thank you so much. I know you put a lot of work into that and obviously diving so into such depth with all those risk scores. That was really great work. Um, any questions from those that we still have with us about anything that was covered today? You're free to unmute yourself and ask a question in these last minutes.
A quick question, Mike. The risk scores, like for example, the STOP RV score calculator, did it indicate how close to surgery they got that score? And did they get it multiple times, or when do they calculate that score? Like when the patient's being evaluated?
Yes, all of these scores are intended to be pre-implant predictors. So you
Like
would,
at the time of the evaluation, when the team is discussing the patient, they'll say, and his score for this was that, and
right,
yeah,
area to be more for the planning of
right.
the potential and predicting what the risk of RV failure is from this.
Some centers are very heavy on these scores, like the frailty scores. Some centers use that for every single evaluation. Do some centers use these RV scores, with every evaluation? Do you know?
No, I'm actually not, I'm not sure, like if Utah, for instance, uses this score for every patient that they evaluate.
Hey, I'm one of the heart failure fellows at Utah. Yeah, we do for our committee discussions. Every LVAD presentation has the Stop RVF calculator.
Excellent, thank you.
And do you use the any frailty score in addition to this, the RV scores?
Yes.
Like looking back at everything, is there, you kind of summarized it there in your takeaway slide, but was there a risk factor score that you would um, put more faith in amongst the others? If you just had to say, well, it seems like you're putting most of your faith in some of the hemodynamic parameters, but is there a risk score that kind of jumped out to you as one that would be the best among them all that we could incorporate into our regular assessment protocols?
Yep, in my opinion, I kind of agree with Utah's program that theirs is the only one that does include uh, some HeartMate 3 patients in making the prediction. And at least some of the sample comes post, August of 2018, when the transplant criteria changed and it changed the landscape. But as we saw, even this predictor is still heavily influenced across a wide time frame, going all the way back to, I think, 2008. Yeah, 2008. But I think this one is probably the one I would select, just because of the representation of HeartMate 3, and it does at least go past August of 2018, when HeartMate 3 became widely available and FDA approved, all the way to July of 2019.
Great. Well, thanks again, Mike, for putting this together for us. Thanks everybody for joining, and hope everybody has a great rest of your afternoon.
Thank you, Dr. Beakley.